Hi guys, my name is Lindsay Owens and I attend school at Southwest Baptist University. In this presentation I will go over the research I found regarding the routine replacement of intravenous catheters versus the clinically indicated replacement of intravenous catheters. So the first question is, why did I choose this topic? I chose this topic regarding IV catheter replacement because I am a healthcare worker. According to Rickard and the other authors of their 2012 study, the protocols regarding routine replacement increases the staff workload by adding a new task to the nurse's already busy day. Another reason I chose this topic is simply because of patient satisfaction. Being a soon-to-be nurse, my patient satisfaction is of importance to me, and who wants to be poked with a needle every 3 to 4 days if it isn't necessary? Not very many people. In addition to this topic being of importance to myself, this is also important to the public, more specifically to individuals who are admitted to an inpatient facility. Rickard also brought attention to the fact that routine replacement requires patients to undergo continuous invasive procedures. If the guidelines and protocols are changed to replacement when clinically indicated, this could increase overall patient satisfaction and safety, according to Morrison and Holt in their 2015 study. The healthcare system is also affected by the routine replacement protocol, as this increases healthcare costs with the continuous use of new IV catheter start sets. Rickard and the other authors of their 2015 study also indicated that IV catheters could be removed when clinically indicated with no increased risk of infection or phlebitis as previously thought. This is why it could be deemed important to the patients of my review. They were involved in new and improved evidence. My PCOT statement is, for patients admitted to the hospital, does routine intravenous catheter replacement compared to replacing it when clinically indicated increase the risk of infection over a 6-month period? So for the first step in my research, I looked for a clinical practice guideline, and under the topic prevention of intravascular catheter-related infections, I typed in peripheral venous catheter. This came up with 17 results, and it pretty much stated that pediatrics IV catheters did not need to be replaced every 72 to 96 hours and should be replaced just whenever it was clinically indicated. Whenever it spoke to adults, it was never very clear as to what was suggested, whether it be routine replacement or replacement when clinically indicated. It just spoke to that the dressing should be changed more frequently than the IV catheter itself due to contamination, or if the patient was diaphoretic, or if it was just peeling off. And then as far as the first database that I went to, I searched under Cinol Complete. I used intravenous catheter and infection and replacement. I came up with 21 results, which was pretty low. It was more low than I expected. And the filters I used were full text and English. I chose the Morrison and Holt 2015 article because it was appropriate to my topic, and the title of the Morrison and Holt 2015 study is called The Effectiveness of Clinically Indicated Replacement of Peripheral Intravenous Catheters, an Evidence Review with Implications for Clinical Practice. The other database that I used was Medline with full text. The Boolean operators I used were intravenous catheter and infection and replacement. The search results were 716 articles, and the filters I used were full text dated between 2000 and 2018, and articles with abstracts available. I came across one article by Webster and other authors in 2008 that was applicable to my research. It was a study done to examine differences in replacing peripheral intravenous catheters when clinically indicated versus routine replacement. It was a randomized control study in one Australian hospital that placed participants into 2 separate groups randomly. And the conclusion was that replacement of catheters only when clinically indicated is preferred due to no significant difference in changing the IVs routinely. The other database I utilized was ProQuest Nursing and Allied Health Source. The Boolean operators I used again were intravenous catheter and infection and replacement. This came up with a lot of results at 4,483. I used the filter full text, and I found 3 different articles that were very applicable to my research topic. And the first one was Rickard and a ton of other authors in 2008 or 2012, and it was to determine if it is necessary to routinely replace IVs or if they can be replaced as clinically indicated. And this study utilized over 3,000 patients. It was non-blind, randomized, multi-center study. And the results of this study were that no patient had local infections. One patient had a catheter-related bloodstream infection in the routine replacement group, and no benefit of routine replacement was identified. And then the other article that I found was by Bramhagen, Lowenhelm, and Idval, and this was a study done to investigate whether peripheral IVs are replaced when clinically indicated in children. And this study utilized under 50 children, and they were observed. And the results of this were that phlebitis occurred in children when it was clinically indicated to remove the IV. Studies suggest that it is not necessary to change routinely, but rather when clinically indicated in children and adults. It suggests that assessment of the IVs is the key in determining complications. And then the last article that I found from ProQuest Nursing and Allied Health source was by Deo in 2017, and this was also done to determine if it was necessary to routinely replace IV catheters or if it was okay to clinically replace peripheral IV catheters. This was a study that involved 73 patients with 286 peripheral catheters in routine replacement and 64 patients in the clinically indicated group that went through 296 catheters. The results of this were that the chi-squared test showed no significant difference in the complication rates between the two groups. Hospitals should switch to the replacement when clinically indicated to spare the patient pain, hospital finances, and nurses' workload. The longest IV in the clinically indicated group was in place for 19 days, and it was then removed because of infiltration. So as previously stated in the slides prior to this, all of the articles in the guideline had the same results and similarities. All of the articles took place in an acute care setting, and all of the articles ultimately came to the same conclusion one way or the other. In the Morrison and Holt 2015 study, replacing peripheral intravenous catheters when clinically indicated does not increase the risk of infection or phlebitis. In the Rickard and other authors in the 2012 study, it showed no benefit of routine replacement. And in the Bramhagen, Lowenhelm, and Idval 2015 study, it suggested that it is appropriate to change IVs when clinically indicated in children and adults. Assessment is the ultimate key in determining complications. In the Deo 2017 article, it stated that the chi-squared test showed that there was no significant differences in the complications between the two groups. And in this article, as I previously said, that the longest IV in the clinically indicated group was 19 days in duration and was removed because of infiltration. This patient could have gone through 4 or 5 IVs if the patient was in the routine replacement. So this kind of goes to show that it does decrease the healthcare working workload and decreases hospital expenses and ultimately increases patient satisfaction because that patient didn't have to go through the 4 or 5 different IVs. And lastly, in the Webster 2008 article, it is preferred for hospitals to switch to clinically indicated replacement due to no significant changes noted between the different groups. As every article and study that I found came to the same conclusion and suggested the same thing, that clinically indicated replacement of IV catheters is preferred over routine replacement, I did not find any inconsistencies upon review of the studies. As far as my review of the articles and studies for gaps and limitations, I did come across a couple. I'll first talk about the Webster 2008 and Morrison and Holt 2015 studies. Both of these took place in just one hospital, so that could be considered a limitation, as if they were to expand their studies to more than one hospital, maybe different regions of the country, this could have gained more data for this kind of study. And then in the Rickard 2012 study, this took place in multiple centers just in Australia at 3 different university-affiliated hospitals. And then in the Bramhagen, Lowenhelm, and Idball 2015 study, it suggested that more research is needed regarding the nurse's clinical decisions. This is talking about why IV catheters aren't being changed routinely, better yet when it is clinically indicated, which leads to phlebitis. We couldn't really study the difference between routine replacement and clinically indicated replacement due to the nurses not changing intravenous catheters even when clinically indicated. And then in the Deo 2017 article, the data collection for each group, the routine replacement and clinically indicated, took place at different times. So in the routine replacement group, the data was collected prior to the new protocol, whereas the data from clinically indicated replacement was collected after initiation of the protocol. So this could just be a limitation as far as maybe the IVs were treated differently before the protocol because there's just a different time, as well as after the protocol for the clinically indicated group. And then for the guideline regarding the prevention of intravascular catheter-related infections, it was a very vague insight on what is recommended in the adult population. It clearly stated the pediatric recommendations, and so this is seen as a gap because this guideline stated how in children it is appropriate to replace when clinically indicated, but had very vague insight on the proper replacement time for adults, which indicates that more research is needed in this area. In conclusion, regarding the studies and articles in the topic research that I conducted, I believe that there is adequate evidence to support a clinical change. In Morrison and Holt, in their 2015 article, they state that the current practice of replacing peripheral IV catheters every 72 to 96 hours does not decrease the risk of infection or phlebitis. According to Rickard, in their 2012 study, they state that changing to the clinically indicated IV replacement could decrease many insertions, discomforts, costs, and workloads. As far as the guideline that I found, the Infectious Diseases Society of America in 2011 stated that no recommendation is made regarding the replacement of peripheral catheters in adults only when clinically indicated, unresolved issue. And then under where they previously mentioned the replacement for pediatric IVs is to be whenever it's clinically indicated, it is stated that it's a Category 1B guideline, and the Category 1B guideline is that it is strongly recommended for implementation and supported by some experimental, clinical, or epidemiological studies and a strong theoretical rationale, or an accepted practice supported by limited evidence. So, in conclusion, each of these studies had results that were significant in the fact that it is not necessary to routinely replace peripheral intravenous catheters.